Ladies and gentlemen, please welcome the always informative and very entertaining Dr. Allen.
Thank you. Thank you. Thank you, Ari. Well, I don't know. I was in the grocery store the other day doing a little bit of grocery shopping, and there's some sort of phenomenon I observed in the produce section. I don't know if you've ever seen this before, but it seems to me that with your age, there seems to be a correlation between how often you squeeze the fruit. I mean, there seems to be some sort of guideline on this. I think you get a squeeze for every decade of life. So if you're 70 years old, you're allowed to squeeze the produce 7 times. If you go over that, you just bought it, my friend. It's now yours.
What about the knocking?
There's knocking. Have you seen this tapping on a plum? What information do you gain from tapping on a plum? I don't know. Maybe it makes them feel better, but don't even get me started on fruit tapping here, Ari. Okay. And now I know as you get older, our joints deteriorate and we suffer from arthritis and things like that. But let me tell you, if you can't get the quarter out of the grocery cart, it doesn't mean you just bought it for 25 cents, okay? I mean, it doesn't mean you can now walk down the street with your newfound bought 25-cent grocery cart, okay? You need to abandon the quarter. It's called theft. You'll wind up in prison for that, okay? And now I know it's a sort of a well-known fact that as you get older, you know, your math skills decline, your ability to calculate might go down a little bit, but I've got to tell you, in a grocery line, a grocery cart filled to the brim does not qualify for the express checkout 8 or less item line. You know what I'm talking about here?
Exactly.
I mean, behind some of those seniors, they've got it filled up to the rim and 8 or less. I mean, this is just frustrating. I mean, if that's what you think qualifies for 8 or less, you don't need the groceries. You need to see your physician immediately.
Or your mathematician.
Or your mathematician, that's right. Ladies and gentlemen, we have a great show for you today. We have our healthcare expert. We have a section we call Second Opinion. We've got our medical expert panel. Please say hello to my good friend, Mr. Ari Kazel. Don't go away. We'll be right back. Before our first guest comes out, usually you and I talk about a few little related healthcare topics. But today I'd like to make it a little bit of sort of medical potpourri. Unrelated things. One thing I've heard people always ask is if a doctor gets paid more if he orders more tests. Have you ever wondered that?
I wondered it, but I just automatically assumed the answer would be yes.
You assume the answer would be yes.
Yes.
Actually, in fact, the answer is no. Your physician does not get paid any more money by ordering more tests on you. It is complete fallacy and completely false. I just wanted to clarify that and clear it up because some people have this misperception about that.
That is good information.
Another thing I want to clear up is people are always wondering why doctors' handwriting is so poor.
Well, I mean, isn't that kind of a stereotype on the prescription?
Well, it is. I mean, whenever you see a scribble, you go, oh, you must be a doctor. Yeah. But, you know, I'd like to clarify why. We don't purposely write with poor handwriting. It's just that we're writing so fast because we're doing so many different things in such a short amount of time, we don't have time to make our writing nice. So it's not that we're trying to make it messy. It's strictly a time-related thing. And I wanted to make a comment. It's rather funny. That people always come to the emergency department where I work, and when they've done some injury to themselves, they always preface it with, I did something really stupid today, doctor. And I always tell them, you know what, I've never seen anyone in the emergency department because they did something smart. And finally, before our next guest comes out, I'd like to make a comment about names and generational issues. And I can tell you this, Ari, that if your first name is Ethel, Edna, or Mabel, you don't have much time left.
Generally speaking.
Generally speaking. Okay, our first guest is a chronic pain physician who practices in Markham and North York, Ontario. He's received many awards and accolades for teaching and clinical practice. Please welcome to the show Dr. Kevin Rod. Kevin, thank you for being on the show.
Thanks, Alan.
Kevin, you wear quite a few hats in the medical world, but today I'd like to talk about chronic pain, because that seems to be your main practice. Just how prevalent is chronic pain in society today?
Unfortunately, it's very prevalent based on the recent data that we have. Something about 20 to 30% of the whole Canadians are suffering from some sort of chronic pain over their lifespan. And
Well, that's phenomenal. That's a quarter of
significant,
people.
yeah.
From chronic pain.
Almost 1 out of every 5 people.
Wow. And why is this important to society in general, this issue of chronic pain?
Because chronic pain, by the name of pain, we think of it about like an that's just a symptom. But in reality, we have to think about it as an illness that affects every single aspect of a human's life.
Such as?
Such as your ability to work, most importantly. That would affect your financial ability to take care of yourself and your family. And then it puts the stress and ability to relate to your family also under a lot of pressure. It's like humans, I call it humans' unseen enemy, because one of the big problems that pain patients have is that nobody can see their issue. If you break a leg, people can see it. If you are bleeding, people can see it. But if you are in severe pain, people cannot see it. So many times they don't even believe that you have so much pain. But at the same time, they have a real pain that's affecting every single aspect of their lives, which is really terrible.
You know, with respects to social stigma in particular, there's the issue of fibromyalgia. And also, as a physician who practices chronic pain, you see a large stigma where there's simply this belief that the entity doesn't exist.
Well, unfortunately, there have been a research done on amount of education that medical students get about chronic pain during their studies. And it turned out that veterinary students actually get more education about chronic pain than medical students. And it's very unfortunate that our general knowledge as general population of physicians about chronic pain is very minimal. And even still today, although there are a lot of new information about fibromyalgia out there, a lot of our colleagues are dismissive and they say that it's just your imagination, while we know that it's a hypersensitization of our nervous system, which is an actual real medical condition.
Just for the record, I treat a lot of patients with fibromyalgia, and it's definitely a real entity. These people suffer tremendously, socially, economically, medically. I hear lots of stories about how their family physicians simply don't believe the condition that they have exists, and it's not constructive. And like you said, where's the education going to come from?
It's just when the physician dismisses a patient's real pain, that feeling of injustice that patient suffers can only make the condition worse.
Wow. Who should be seeing these people with chronic pain? Should it be managed by their family physician, or should they be seeing a chronic pain specialist? Does it depend on the level of pain, severity, how long it's been lasting for?
Well, luckily lately there have been a lot more information out there that physicians can access compared to before. There are a lot of national guidelines that came out, and any family physician can access that and to a certain level treat the average pain patient. But when it comes to more complicated cases, they can certainly, or they have to certainly make a referral to pain clinics.
Do you feel that family physicians are under-managing patients with chronic pain? And then my impression sometimes is there are certain physicians, and I guess it's very physician-specific, who are quite readily able and willing to treat their chronic pain patients, and those who really try to shuffle them out the door and send them to a pain clinic.
Well, historically, our problem has been to go from one extreme to another extreme. It's like a pendulum that's going back and forth, and we are hoping to come into a logical, mainstream, midline type of treatment, that all physicians would follow certain guidelines and treat these patients in a human way, not in a dismissive way.
You mentioned treatment. What are the treatment modalities out there available for people with chronic pain?
The best evidence that we currently have suggests multidisciplinary or interdisciplinary type of treatment. Where
what does that mean?
Well, that would be, combination of physical treatments like exercise, physiotherapy, chiropractic, massage therapy, and medications and injections, but not dumping all of them in one patient. It's all very case dependent based on patient's needs.
One of the barriers I've encountered is that people simply don't have the coverage to pay for these therapies that aren't covered by OHIP.
That's true. And that's where a very important point comes into the play, which is called patient self-management. A part of what we have as the role of physician is to teach patients how to manage their conditions. We can teach them about home exercise. We can teach them about what kind of food to eat, what kind of healthy diet to have, and we can teach them about stress management and meditation. But there are a lot of things that we can teach them that would help them to manage their condition much
one of the concerns I have with our aging population and the number of seniors in the future that are going to increase, is this chronic pain going to be the silent pandemic as our population ends?
I believe it is already. It is already. When one every out of 5 people have it, and nobody is talking really about it. If you have 20% of Canadian society having any medical condition, you would hear about it every day in the news, but not much is being said about it. And I believe that already we have this pandemic, and it is a silent enemy of human.
Kevin, thank you very much. I appreciate you coming on to the show. Don't go away. We'll be right back after these messages. Welcome to our medical expert panel discussion. To the right of me, Dr. Paul Drusen, a family physician who's practiced emergency medicine, hospital-based medicine, rural and family medicine. To the left of me, Dr. Roman Allison, who's a family physician who currently practices in Toronto, but has worked in rural regions, the emergency department, and as a hospitalist, and currently has a house call service in Toronto as well. Gentlemen, I thank you for being on the show. Let's get right down to it. We live in a country where our healthcare system is cherished and is seen as one of the founding blocks of our system. There's been discussion recently about two-tiered healthcare system in private healthcare. I would suggest to you that we already have a two-tiered healthcare system. Your thoughts, Paul?
Well, I agree that different people in our society have different access to the medical system, despite our attempts to make it fair.
Who might these people in society be?
Well, first of all, the very wealthy can fly to the United States.
Okay. But is that two-tiered within our system, or the ability to move to another system?
Well, whatever. The people in our country are able to get health care. If they're rich enough, they can get the health care they want. They can pay for it and have it.
But what about within our country, Roman? People who don't decide to fly abroad for health care, but within our healthcare system and stay in our country, is there a two-tiered system already?
Yeah, there is. I mean, you know, the wealthy, well, as Paul said, of course, they could go to the U.S. south of the border, but quite often, you know, if you happen to be wealthy or powerful, you'll probably know physicians in certain prominent positions. You can, you know, you can speed along your treatment if you really wanted to in this.
So you're saying, is it common practice then, to those who are socially connected to people such as physicians or people in the healthcare system, hospital board administrators, is it common practice for them to pick up the phone, make a phone call, and simply jump the queue and get treatment?
I don't know if it's common practice for them because I don't know who they are, but I think I know that it happens, and I've seen it happen. So I would imagine, I mean, wouldn't you? I mean, if you needed a doctor and you knew a doctor, would you not exercise that sort of, no, it's not a right, but would you not exercise that privilege?
Well, I think that would be human nature.
Right,
I mean,
exactly.
if you had a medical problem and you had an ability to jump the queue, you probably would use it.
Absolutely.
There's many inequalities in our society, okay? And I would think that medicine in Canada, we've done a very good job of trying to erase those inequalities. It's obviously not perfect, but that is the theory behind it. It's a very socialist system, probably one of the most in the world. So,
I mean, I agree with, you know, in a perfect world, anyone from, you know, any walk of life could just call up their personal doctor and, you know, be seen or get some advice. But that's not obviously going to happen. I think we sort of maintain a certain level of service and level of care for everybody, and I think we should be proud of that. I mean, we're probably, like Paul said, I don't know, but I think we are probably the only country in the world. Maybe there are others.
North Korea and Cuba.
Right, exactly. And I think that's a good thing. I would kind of like it to stay that way. I'd like it to not necessarily. So I should say that I don't necessarily want to see an institutionalized two-tier system, but you're not gonna, you know, you can't eliminate the, you know, the two-tieredness.
So can we agree then that a two-tiered system on some level currently exists? And it's not necessarily in a private healthcare system, it's within the public healthcare system. I, for instance, know as a physician myself, if I need care, I know I'm going to get it in a more timely fashion than your average person out there. Now, the other question is that right or wrong? there's two-tiered systems in everything in healthcare. There's two-tiered law. If you have the resources, you can purchase the services of a better lawyer than someone who might not have the same resources. Same thing with your accountant. So a two-tiered level exists in every professionalism, probably in every industry in society there is, but somehow in Canada we place this taboo on the same thing happening in medicine. The question is, why is that, and is it wrong?
Well, the taboo exists because, as a society, we decided that medicine is a right to all Canadians, and therefore we're going to make it as equal as possible. We haven't said the same thing about dentistry or about accounting or certainly not law. There's probably realms in our society that probably it applies to just as much, if not more, than medicine. But for some reason, where things developed historically, we have decided that medicine is a right and it should be equal for all. Obviously, we cannot achieve that. But we are and another question is, should we be trying to achieve it? But we as a society are working towards it.
Yeah, I don't think we could ever achieve perfect equity, but I think what we're trying to work towards is to minimize, the difference between someone who's a multimillionaire and someone who, lives at a subsistence level.
Well, I don't think it's necessarily a financial class issue. You don't have to be a multimillionaire to know a physician or have a connection. But,
Yeah,
but it does apply to that, because I will tell you in the hospital that donors who have donated large sums of money to the hospital, when they present to the emergency department, I can tell you that a little secret phone call gets made from the hospital administration down to the department to notify them that this person is here and this person needs to jump the queue.
Well, you know what? That's actually probably not legal.
I don't know the legalities of it, but I know it occurs.
Right.
And is it acceptable in our society? Or do we sort of say that enough people are getting enough health care in enough of a timely fashion that we can turn a blind eye and overlook that because there's really no way of snuffing it out from its roots? Because we know human nature prevails pretty much over any sort of regulation that we try and institute.
It's also human nature to try to regulate and try to make things equitable and fair.
Well, we know that Canada is full of regulators. They're called their government. And I don't think they're going to be going anywhere anytime soon, gentlemen. So I think we're going to have to live with regulation, and this is the system we have for now. So be it. Gentlemen, thank you very much. I appreciate your opinions. Don't go away. We'll be right back. This is a segment we call Second Opinion, where Kevin and I talk about questions from actual viewers from the SenioLand.com website that have sent in questions about medical-related issues. Kevin, I think you had a question from someone in our viewership there.
Yeah, a very interesting question, a very touchy one. The end-of-life decisions. Who really is allowed to make those end-of-life decisions? And who should be making those decisions?
Okay, so who should or makes the end-of-life decisions?
All of these sorts of question came up.
Well, that's an important thing. As our population ages, this is going to become more and more common and prevalent. Really, in an ideal world, end-of-life decisions should be made by the person whose life it is at a point when they're capable of making those decisions. So this is where you get into sort of living wills and things like that, where people sort of state what their preferences would be should they become debilitated or in a life-threatening state, how would they want to be cared and what level of care they want. But assuming that doesn't occur, there's usually a power of attorney or someone who was granted responsibility for looking after those person's wishes when they become in an incapacitated state. Now, these power of attorneys usually are family members, and they're usually, for the most part, present when someone, for instance, is transported to the emergency department in bad condition. We often have discussions with them about what the patient would have liked and would have wanted, and then it's what the family or power of attorney might want as well, but we try and keep it focused on what our beliefs of what the patient would have wanted had they been able to verbalize or state in a coherent way what their wishes would have been.
Right. How would you know what the patient would have wanted? Is it based on what an average person would want?
Well, we rely on family members,
right.
What family members tell us about what the patient's wishes would have been, and then you have to use some sort of judgment. If there's no sort of directive as to what level of care, then by default we provide them with all the care that we deem is necessary in order to treat them. Unless stated otherwise, we will never withhold life support from anyone in the emergency department, and we will never withhold treatment from them unless it's in a directive stated or by family's wishes or something like that. So no one ever has to worry about coming to an emergency department if you're in a bad situation and we're just going to suddenly withdraw care. This is all done in consultation, and by default, we will always provide care for you, and we will always act in your best interest as the physicians and the nurses.
Okay, thank you.
That concludes Second Opinion for today. Don't go away, we'll be right back. Ladies and gentlemen, I want to thank all my guests for taking the time out of their busy schedules to join us today on the show. I want to thank my better half, Mr. Ari Kazel. We hope you found the show to be both entertaining and informative. Until next time, I'm Dr. Allen, yours in good health.